Hello. First of all, I would like to thank the organizers for their very kind invitation. My name is Tarek Sharsha. I'm a professor of intensive care medicine and also a neurologist. I will give this talk with Dr. Aurélien Mazereau, who is an anesthetist and intensivist. Brain dysfunction is very frequent in septic patients. It can occur in up to 50% of cases. It is a clinical marker of onset of sepsis, uncontrolled sepsis, or relapsing sepsis. It is characterized by an impairment of consciousness ranging from delirium to coma. Therefore, it can be detected clinically with using appropriate scales such as CAM-ICU for delirium or Glasgow Coma Scale or 4-score for coma. Because it is an encephalopathy, it is associated with EEG abnormalities. Therefore, EEG can be used for detecting or monitoring brain dysfunction in septic patients. It is a severe condition as it is associated with increased mortality in up to 60% according to the severity of disorders of consciousness. It is also associated with long-term cognitive impairment and long-term psychological disorders. Girard has shown that sepsis is one of the major causes of delirium in septic patients, along with hypoxemia, metabolic disturbances, and sedation. EEG features of delirium in septic patients include delta predominant activity, low voltage, electrographic seizures, but also triphasic waves and periodic discharges, and less frequently, absence of reactivity. EEG can be malignant according to the Synod score in up to 36% of cases. Long-term psychological disorders include anxiety, depression, and PTSD in critical ill patients, and therefore in septic patients. And in the graph, you can see that there is a proportional correlation between the rate of hospitalization for sepsis and the risk of suicide. It has been shown that critical ill patients can develop long-term cognitive disorders, and that there is a proportional correlation between the duration of delirium during the ICU stay and the severity of cognitive disorders. Cognitive dysfunction involve memory, executive function, attention, concentration, and verbal fluency. Among critical ill patients, septic patients are at high risk to develop cognitive disorders, as it has been shown in patients admitted in ICU for pneumonia. But there is a reciprocal relationship between pneumonia and neurodegenerative disorders. We know that patients with neurodegenerative disease can develop aspiration, and aspiration in turn can aggravate neurodegenerative process. And there is also a proportional correlation between the rate of hospitalization for sepsis and the severity of cognitive dysfunction.
The pathophysiology from sepsis-associated encephalopathy starts from the activation of the immune system that produces a systemic cytokinic storm. Three main processes occur in the brain in response to these cytokinic storms, which are the excitotoxic process, the neuroinflammatory process, and the micro-macrovasculature activation. All these lead to hypoxia in the brain, neuronal apoptosis, and dysfunction, which explain the increased mortality associated with SAE. The pathological changes that are observed during SAE are gathered on this slide. First, there is vascular changes such as lacuna, large ischemic stroke, but also hemorrhage with microhemorrhage and hematoma in the brain. There is also the neuroinflammatory process that is observed in pathology and through astrogliosis, microglial activation, axonopathy, and neuronal death, but also blood-brain barrier dysfunction that have been evidenced in electron micrographs, but also in a study in which patients with sepsis underwent an underwent an MRI, and it evidenced an increased visceral spaces and changes that are presented on this MRI. The vascular changes are leading to an ischemic process. The ischemic process results from the activation of the coagulation in the blood, meaning the disseminated intravascular coagulation that leads to a large ischemic stroke, but also to micro perfusion and perfusion alteration. First, the smooth muscle cells from pyoidal arteries and penetrating arterioles are altered during sepsis. They usually are responsible for the autoregulation that ensures a constant blood flow under different blood pressure and systemic hemodynamic changes. This process is altered during sepsis, leading to an increased risk of confusion. Also, there is microperfusion alteration, and some capillaries are not perfused, and it increases also hypoxia. Lastly, there is the neurovascular coupling that is altered. It is the mechanism in which pericytes induce microdilatation of vessels in response to an increased neuronal activity, and this is also impaired during sepsis. You can see here that has been evidenced ischemic, a large ischemic stroke in a patient that was hospitalized for sepsis in our world. The neuroinflammatory process is depicted here. On the left side, you have a healthy brain with its different cellular contents, and on the right side, you have what occurs during sepsis. First, there is an endothelial activation that leads to the secretions of cytokines locally that will activate astrocytes, microglial cells, and astrocytes are here, that will produce reactive oxygen species that will injure the oligodendrocytes and the neurons, and it will lead to the excitotoxic cascade and neuronal cell death. What happens during the excitotoxic cascade? It is shown here. First, the interneuron, which is the most sensitive to hypoxia, is dysfunctional. Its role is to inhibit the excitatory tone of excitatory synapses. This dysfunction will lead to an increased concentration of neurotransmitter in the synapse and will increase the rate of action potential on the postsynaptic neuron, and it is what is called the excitotoxicity. It will lead to energy crisis, mitochondrial dysfunction, and cell death. This is worsened by the impairment of astrocytic functions, which are to reuptake neurotransmitter, control microenvironment, and support neuron through energy supply. This leads to impairment of functions, and we have addicted a paradigm in which we graduated the response of the central nervous system to the sepsis. First, there is the sickness behavior, which gather the comportamental changes, supposed to be physiological, but is at the line with pathologies, and the delirium is a pathological response of the CNS, or dysfunction of the CNS, and an increased sensitivity to sedation or coma is the worst form of encephalopathy. All of these rely on different cerebral regions that are also the anatomic substratum of long-term impairments in the brain. It has been modelized in rodents, but also observed in patients. And one of the first function that is altered is the vasopressin secretion. What you see here is the response of patients that have sepsis of vasopressin secretion in response to an osmotic charge. Some patients are responders to this osmotic charge, and some are not. This impairment can last during time and is associated with outcome. It has been modelized in a rat model of sepsis, and the neurons from the alveoli and the supraoptic nuclei have been evaluated. These neurons present an hyperpolarization state with less action potential in response to osmolality changes. This is the substratum for the one of function impairment. Another impairment that we have observed is the behavioral changes. In a study, we have observed patients upon ICU admission and evaluated their level of anxiety. We separated the cohort in the patients with high anxiety and low anxiety, and we have shown that it is associated in the first 7 days with the occurrence of a new organ failure. And this is independent of the observable severity upon admission. Finally, there is also changes, long-term consequences, of sepsis, which is anxiety and post-sepsis syndrome. It is a very important focus today, and we have modelized this post-sepsis syndrome in a mice model of sepsis, leading to anxiety and PTSD-like behavior. In this model, we have manipulated the activation of one specific center, which is the central amygdala nuclei, that is early activated during sepsis. That is what you observe here in a calcium imaging. The mice with CLP have an increased activity in these neurons, whereas in sham or control mice, there is no increased activity. When you inhibit these neurons through pharmacogenetic modulation, what you observe is that you lower the post-traumatic stress disorder-like syndrome after sepsis. Here it is evidenced by the freezing time response to an electric shock and its memorization. And what you see is that in sepsis it is increased, and when you inhibit this center, this response comes back to control values.
There are arguments for a brainstem dysfunction in septic patients. As you know, brainstem control the arousal via the reticular activating ascending system. It controls the autonomic function. It controls breathing, and also brainstem reflexes that can be assessed clinically. Therefore, a dysfunction at the level of a reticular activating system can account for delayed awakening and delirium. And it has been shown that sepsis is associated with impaired heart rate and blood pressure variability that can be related to dysfunction at the level of the brainstem autonomic nuclei. It has also been shown that there is an impaired variability of the tidal volume that can reflect also a dysfunction at the level of the respiratory nuclei within the brainstem. And interestingly, it has been shown that the impairment of heart rate variability is associated with mortality and the impairment of tidal volume with weaning failure. Neurophysiological studies have shown that there is an impairment of the connection of evoked potential at the level of the brainstem, either somatosensory evoked potential or auditory evoked potential. And neuropathological studies have evidence that neuronal apoptosis within autonomic nuclei, but also the nuclei of the reticular activating ascending system. We have assessed brainstem reflexes in critical ill patients, especially septic patients, who require deep sedation. And we have evidenced two patterns of abolition of brainstem reflexes. The red one, or homogeneous pattern, which is characterized by an abolition of all brainstem reflexes or the presence of all brainstem reflexes, meaning that they are either all abolished or either all present. The second pattern is characterized by a heterogeneous abolition of the brainstem reflexes. It is in blue in this graph, and as you can see, the grimace and the oculocephalogy reflex can be abolished, while the corneal, the pupillary light reflex, and the coral reflexes are present. We have found that the heterogeneous and homogeneous patterns are respectively seen in half of our cohort, and we have found that the heterogeneous pattern is associated with increased mortality with an odds ratio about 7, even after adjustment to the severity of critical illness and depth of sedation. There are other arguments for a brainstem dysfunction. For instance, we have found that the absence of reactivity in septic patients on EEG was associated with increased mortality. And this absence of reactivity in EEG can be related to a dysfunction at the level of the reticular activating system. It has been shown that sepsis can be associated with an impairment of brain-heart coupling, meaning a discorrelation between EEG variability and heart rate variability. And this brain-heart discoupling can be related to a brainstem dysfunction. And as a formation, we have found that increased latency of the SSEP, so somatosensory evopotential, or AEP, or auditory evopotential, are respectively associated with increased mortality and delirium. And we have just achieved a multi-center observational study on multimodal assessment of deep sedated patients in order to determine whether clinically brainstem dysfunction or neurophysiological brainstem dysfunction are associated with mortality, delayed awakening, and long-term outcome. So what about the treatment of septic-associated encephalopathy? For any of the main mechanisms of brainstem dysfunction, ischemic process, neuroinflammation, and excitotoxicity, there is no preventive or curative strategy that have ever been shown to be beneficial. Many have been tested experimentally, and we will focus on very few of them who have been tested in septic patients. It has been previously shown that dexmedetomidine can be beneficial in septic patients. However, a very recent randomized clinical trial has shown that dexmedetomidine is not superior to propofol for sedating septic patients. Indeed, it doesn't increase the number of delirium coma-free days, and it has no impact on mortality. Statin is known to modulate microglial activation, and it has been shown to be beneficial in septic mice for reducing cognitive impairment, but in patient and in septic patient, it has not been shown to be beneficial in terms of delirium prevention, treatment, or in terms of prevention of long-term cognitive impairment. Rivastigmine also has been proposed for modulating microglial activation in critical ill patients, but the clinical trial on rivastigmine has been discontinued earlier because of very severe side effects without any impact on delirium. This trial illustrates how it is difficult to test drugs, modulatory drugs on microglial activation. And we think that the main reason for that is that we do not have any biomarkers of microglial activation and markers of immunophenotype of microglial cells. Why levetiracetam? Preliminary studies done in our laboratory in Pasteur Institute have shown that in addition to its anti-epileptic properties, levetiracetam can modulate microglial activation. Therefore, we have decided to carry out a clinical trial and levetiracetam in septic shock patients in order to assess whether it can increase the number of delirium coma-free days. And this clinical trial will start in the soon. So, in conclusion, brain dysfunction is frequent and it is associated with increased mortality and long-term psychocognitive disorders. It can be detected clinically or by EEG. As physicians, we have to discuss CSF analysis if there is any doubt for meningitis. We have also to discuss a neuroimaging if there is an unexplained disorder of consciousness, seizure, or focal neurological sign. It is related to complex pathophysiological mechanisms, including ischemic, neuroinflammatory, and excitotoxic processes. It seems that some brain regions are more vulnerable. For instance, the limbic system, especially the amygdala, whose dysfunction can account for long-term psychological disorders, hippocampus and frontal lobe, whose dysfunction can account for long-term cognitive impairment, and brainstem autonomic nuclei, or who dysfunction can account for delayed awakening, multiple organ failure, and mortality. There is no specific treatment for sepsis. It is really important to apply guidelines on delirium and also to control sepsis. We would like to thank all our friends and collaborators, and we thank you for your attention.